Welcome to the first part of the presentation on acute intracranial problems. The rigid cranial cavity created by the skull is normally filled to capacity with three essentially non-compressible elements: the brain, which makes up about 80%, the cerebral spinal fluid, which makes up approximately 8%, and the blood, which makes up approximately 12%. The Moreau-Kelly hypothesis states that if the volume of any of the three components increases, the volume of the others must decrease to maintain normal pressures within the cranial cavity. Brain tissue's ability to accommodate change is relatively restricted. Displacement of some CSF to the subarachnoid space and increased CSF absorption are early compensatory mechanisms. Cerebral arteries constrict to reduce blood flow. When the capacity to compensate for increased intracranial pressure is exceeded, increased intracranial pressure develops. Intracranial hypertension is a sustained state of increased intracranial pressure and is potentially life-threatening. Nursing management of the patient with an acute intracranial problem must include management of secondary injury and increased intracranial pressure. Primary brain injury occurs at the time of the accident when damage results from the sudden distortion of brain tissue within the rigid skull. The damage sustained may be focal or diffuse. Focal means, for example, a localized blow to the head. Diffuse, for example, would mean typically occurring in high momentum impacts. Only prevention and protective devices can reduce primary brain injury. The medical team's actions could reduce the impact of primary injury by preventing, identifying, and treating secondary injury to the brain. Secondary brain injury is caused by systemic factors such as hypotension or hypoxia, and by compression of brain tissue. Compression is caused by swelling of the brain itself or by the development of hematomas. If this compression is localized, then the brain may shift within the fixed dural and bony structures that contain it. Secondary injury can occur several hours to days after the initial injury. Regulation and maintenance of intracranial pressure depends on normal compensatory adaptations, such as changes in cerebral spinal fluid volume, changes in intracranial blood volume, and changes in tissue brain volume. The ability to compensate is limited. If volume increase continues, intracranial pressures rise, leading to decompensation, which leads to compression and finally ischemia. Many factors influence intracranial pressure. Cerebral autoregulation is the automatic adjustment in the diameter of the cerebral blood vessels by the brain to maintain a constant blood flow during changes in arterial blood pressure. The purpose of autoregulation is to ensure a consistent cerebral blood flow to provide for the metabolic needs of brain tissue and maintain cerebral perfusion pressure within normal limits. The lower limit of systemic arterial pressure at which autoregulation is effective in a normotensive person is a mean arterial pressure of 70 millimeters of mercury. Below 70, the cerebral blood flow decreases, and symptoms of cerebral ischemia, such as syncope and blurred vision, occur. Carbon dioxide, oxygen, and hydrogen ion concentration affect cerebral blood vessel tone. An increase in the partial pressure of dissolved CO2 in arterial blood relaxes smooth muscle, dilates cerebral vessels, decreases cerebrovascular resistance, and increases cerebral blood flow. A decrease in the partial pressure of CO2 constricts the cerebral vessels, increases cerebrovascular resistance, and decreases cerebral blood flow. Hyperventilation is one known method of rapidly lowering intracranial pressure. Cerebral blood flow is largely dependent on the partial pressure of dissolved CO2 in the arterial blood. Hyperventilation causes decreased partial pressures of CO2, which leads to arterial vasoconstriction, thus lowering cerebral blood flow, cerebral blood volume, and intracranial pressures. Body position is another factor that influences intracranial pressures. Proper head positioning of the patient is very important. Keeping the head in a midline position and avoiding extreme neck flexion will help to decrease intracranial pressures. Flexion can cause venous obstruction and contribute to the increased intracranial pressure. We want to make sure that there is no obstruction so that venous blood from the upper body and head can return to the right side of the heart. Adjusting body position to decrease the intracranial pressure helps to improve the cerebral perfusion pressure. 30 degrees is that magical number for the neuro nurses. They know that keeping the head of the bed at 30 degrees will optimize cerebral perfusion pressure and lower the intracranial pressure. Increased intracranial pressure is clinically significant because it decreases cerebral perfusion pressure, increases the risks for brain ischemia and infarction, and is associated with poor prognosis. It is critical to maintain cerebral blood flow to preserve tissue and thus minimize secondary injury. The blood supply of the brain arises from the internal carotid arteries, which supply the anterior circulation, and the vertebral arteries, which supply the posterior circulation. The major arteries to the head are the common carotid and vertebral arteries. On the left side of this slide, you can see an inferior view of the brain showing the vertebral, basilar, and internal carotid arteries and their branches. Note that each internal carotid artery supplies the ipsilateral hemisphere. That means the hemisphere on the same side of the head. The basilar artery, formed by the junction of the two vertebral arteries, supplies structures within the posterior fossa, including the cerebellum and the brain stem. At the base of the brain, the circle of Willis arises from the basilar artery and the two internal carotid arteries. This vascular circle may act as a safety valve when differential pressures are present in these arteries. The cerebral perfusion pressure, or CPP, is the pressure needed to ensure blood flow to the brain. The CPP is equal to the mean arterial pressure minus the intracranial pressure. So we have that equation stated at the bottom of this slide. CPP is equal to the MAP minus the ICP. The normal CPP is 60 to 100 millimeters of mercury. As the CPP decreases, autoregulation fails and cerebral blood flow decreases. A CPP of less than 50 millimeters of mercury is associated with ischemia and neuronal death. A CPP of less than 30 millimeters of mercury results in ischemia and is incompatible with life. Normally, autoregulation maintains an adequate cerebral blood flow and the cerebral perfusion pressure by adjusting the diameter of the cerebral blood vessels and other metabolic factors that affect intracranial pressure. Again, it is critical to maintain mean arterial pressure when the intracranial pressure is increased. Increased intracranial pressure is clinically significant because it decreases cerebral perfusion pressure, which increases the risk for brain ischemia and infarction. It is associated with a poor prognosis and can be life-threatening. There are stages of increased intracranial pressures. Sustained increases in intracranial pressure result in brainstem compression and herniation of the brain. Herniation occurs as the brain tissue is forcibly shifted from the compartment of greater pressure to a compartment of lesser pressure. Displacement and herniation of brain tissue can cause a potentially reversible process to become irreversible. Ischemia and edema are further increased, compounding the pre-existing problem. Compression of the brainstem and cranial nerves may be fatal. Herniation forces the cerebellum and brainstem downward through the foramen magnum. If compression of the brainstem is unrelieved, respiratory arrest will occur due to the compression of the respiratory control center in the medulla. In this situation, intense pressure is placed on the brainstem. If herniation continues, brainstem death is imminent. As mentioned earlier, brain herniation is a lethal complication of increased intracranial pressure, resulting from the displacement of brain tissue from its normal compartment. There are different categories of brain herniation. In umbilical herniation, a common subtype of herniation, the innermost part of the temporal lobe, the uncus, can be squeezed so much that it moves toward the tentorium and puts pressure on the brainstem, most notably the midbrain. The uncus can squeeze the oculomotor nerve, which is cranial nerve number 3. This may affect the parasympathetic input to the eye on the side of the affected nerve, causing the ipsilateral dilation of the pupil. The pupil of the affected eye dilates and fails to constrict in response to light as it should. So again, with an uncal herniation, we have a lateral injury which causes the brain tissue to shift to the other side and squeezes the brain tissue downward in a downward motion, which squeezes the oculomotor nerve, causing an ipsilateral dilation of the pupil. Let's look at some other manifestations of increased intracranial pressures. Decreased level of consciousness. In most cases, this is an early sign of increasing intracranial pressure. Expect the patient to have subtle changes in their assessment with small changes in intracranial pressures and drastic changes in an exam with drastic elevations in their intracranial pressure. That is why a nurse's baseline exam is so important. By detecting signs and symptoms of increased intracranial pressure early, we have the best chance of intervening before it's too late for medical treatments to be effective. So here we have a review of changes in level of consciousness. Remember, these are subtle changes and take skill to pick up on. So we go from an alert state where the patient is able to follow commands and respond appropriately to stimuli, to lethargic, which is like drowsy, and they have a delayed response to verbal stimuli. This is followed by a stuporous state, and then finally a comatose state in which the patient doesn't respond appropriately to verbal or painful stimuli. And then we also have to review the term obtunded. Obtunded means that the patient's responds to light shaking, but is slow to respond and may be confused. Compression of cranial nerve 3, the oculomotor nerve, results in dilation of the pupil on the same side, ipsilateral, as the mass lesion. Sluggish or no response to light, inability to move the eye upward and adduct, and ptosis of the eyelid. These signs can be the result of the brain shifting from midline, compressing cranial nerve 3 and paralyzing the muscles controlling pupillary size and shape. In this situation, a fixed, unilateral, dilated pupil is considered a neurologic emergency that indicates brain herniation. Although the brain itself is insensitive to pain, compression of other intracranial structures such as arteries, veins, and cranial nerves can cause a headache. A nocturnal headache and/or a headache in the morning is cause for concern and may indicate a tumor or other space-occupying lesion that is causing increased intracranial pressure. Straining, agitation, or movement may worsen the pain. Vomiting, usually not preceded by nausea, is often a nonspecific sign of increased intracranial pressure. This is called unexpected vomiting and is related to pressure changes in the cranium. Projectile vomiting may occur and is related to increased intracranial pressure. Diagnostic studies can be used to identify the cause of increased intracranial pressures. CAT scans and MRIs are used to discern the many conditions that can be causes for increased intracranial pressure, and also to assess the effect of treatment. Other tests include EEGs and cerebral angiography. Remember that angiography involves the introduction of a dye or contrast media into the vasculature of the cerebrum. It is an invasive procedure. So once again, we have to remember to observe the patient for bleeding at the puncture site, which frequently would be the groin. Other tests include ICP measurement and brain tissue oxygenation measurement via the Lycox catheter. ICP measurement or monitoring is used to guide clinical care when the patient is at risk for or has elevations in intracranial pressure. It may be used in patients with a variety of neurological problems, including hemorrhage, stroke, tumor, infection, or traumatic brain injury. The Lycox catheter is placed in healthy white matter of the brain and measures brain oxygenation and temperature. Systems such as this provide a continuous monitoring of the pressure of oxygen in brain tissue. A low level of oxygen indicates ischemia. These catheters can also measure brain temperature, and a cooler brain temperature may produce better outcomes.